Bismillahirrahmanirrahim. Quote of the day: Life doesn't come with a manual, it comes with a mother. Today, the topic of my presentation is Safe Motherhood under kind supervision of Professor Dr. Saira Afzal. Learning outline of today's presentation is about the introduction, a safe motherhood initiative, pillars of safe motherhood, strategies of safe motherhood, recent update, and at the end, there is an MCQ session. By the end of this presentation, participants will be able to describe the introduction, safe motherhood initiative, pillars of safe motherhood, and strategies of safe motherhood. What is maternal death? The annual number of female deaths from any cause related to or aggravated by pregnancy or its management during pregnancy and childbirth or within 42 days of termination of pregnancy, irrespective of duration and site of pregnancy. There are multiple causes of maternal death, like indirect causes, severe bleeding, sepsis, eclampsia, obstructed labor, unsafe abortion. And the massive number is severe bleeding, postpartum hemorrhage. Summary of cause of maternal mortality. Indirect causes, there is hemorrhage, hypertensive disease, infection, induced abortion, extrauterine pregnancy. And in indirect causes, there are some other infectious diseases like hepatitis, HIV, AIDS, malaria in pregnancy, sickle cell disease, meningitis, heart disease in pregnancy, acute renal failure, tuberculosis, and diabetic ketoacidosis. In 1930, the League of Nations Health section noted concern about maternal mortality. The first international conference of safe motherhood was in 1987 Nairobi. It led to the formation of an interagency group for safe motherhood to reduce maternal mortality in developing countries by 50% in 1 decade. Now, what is safe motherhood? Safe motherhood means ensuring all women receive the care they need to be safe and healthy throughout pregnancy and childbirth. Motherhood should be a time of expectation and joy for a woman, her family, and their community. And the goal of safe motherhood is to improve well-being of mothers through a comprehensive approach of providing, preventing, promotive, curative, and rehabilitative health care. There are some objectives of safe motherhood: to improve quality and increase access to family planning and maternal health care services, to educate couples to ensure they have the best chance for a wanted and safe pregnancy, to promote improvement of system for monitoring maternal and newborn health service, to promote the implementation of evidence-based integrated cost-effective reproductive health intervention with a focus on maternal and newborn health within primary healthcare approach, to conduct operation research to generate best practices and evidence for addressing priority reproductive health problems. This is the basic structure of safe motherhood, and there are in first safe motherhood structure their design there are 4 pillars, and these are that 4 pillars. But in new safe motherhood approach there are 6 pillars, and these 4 are old one, and the new thing that are added is primary health care and equity for women. And the 4 pillars of safe motherhood is family planning, antenatal care, clean, safe delivery, and essential ops care. This is also a design of safe motherhood in which community, communication, antenatal care, neonatal care, postnatal care, and family planning, emergency transport, emergency and neonatal care, emergency ops and neonatal care services, and equity for women. These are the 6 pillars of safe motherhood: family planning, antenatal care, ops care, postnatal care, post-abortion care, STD and HIV control, communication for behavior change, primary health care, equity and education for women. First pillar is family planning. What is family planning? Information and services to plan the timing, number, and spacing of pregnancy. Antenatal care for early detection and treatment of complication of pregnancy. Ops care provide proper knowledge and equipment to the birth attendant and ensure emergency care for high risk pregnancies. Ops and newborn care. Ops and newborn care refers to all the care and healthcare level initiative provided to the mother and newborn to reduce maternal and newborn mortality and morbidity. Birth attendant should have the knowledge, skill, and equipment to perform a clean and safe delivery. Moreover, emergency care for high risk pregnancy and complications are made available to all women and newborn who need it. Essential ops and newborn care. Essential ops and newborn care encompass all care that is provided during pregnancy, labor, childbirth, and postpartum period to prevent and manage complication. It is a term used to describe the elements of ops and newborn care needed for the management of normal and complicated pregnancy, delivery, and postpartum period. Essential ops and newborn care is differentiated into two levels. Comprehensive emergency ops and newborn care. It includes all the services of basic essential ops services along with following additional services. Caesarean section and surgery, blood transfusion, anesthesia, umbilical vein insertion, and intubation of the newborn. Comprehensive emergency ops and neonatal care services are basically provided at the referral hospitals by physician, clinicians, or especially trained midwives. Postnatal care for both mother and her baby includes lactation assistance, family planning services, and management of complications of delivery. Post-abortion care, management of complication and family planning consultation. Post-abortion care save life. Abortion may be illegal, but post-abortion care is always legal. STD and HIV control, voluntary counseling and testing, prevention of mothers to child transmission. This is the safe motherhood pillar, which are used in resource limited setting. In resource limited setting, you can focus on these headings like community programs, referral, emergency transport, and emergency ops and neonatal care services. In emergency ops care, there are 8 points which you can follow. And these 8 points are antibiotic, oxytocic drugs, anticonvulsants, blood transfusion, manual removal of placenta, retained product of contraception, and assisted vaginal delivery, and the C-section. These are the 8 things which are covered in emergency ops care. Approaches to attain safe motherhood. If we want to attain safe motherhood, then there are 3 domains which are covered: antenatal care, intranatal care, and postnatal care. In antenatal care, the team should home visiting, prenatal clinics, and observation beds. And in intranatal care, there is domiciliary midwifery service, medical advice by MO, maternity homes, safe kids to train birth attendants, diagnostic facility, and ambulance services. And in postnatal care, home visiting, supply of milk, health education, weight of baby, and hospital beds. Safe motherhood strategies. In safe motherhood strategies, there is tetanus immunization, access to maternity care, availability of trained birth attendant, providing a clean environment for the birth, referral center, emergency ops care, health education, family planning, SOPs and training, intersectoral coordination, and community participation. What are the things that are not fulfilled to achieve the safe motherhood? And these are 3 delays model. 3 delays are primary prior to maternal death: delay in seeking care, delay in reaching care, and delay in receiving care. Delay in decision to seek care, lack of understanding of complication, acceptance of maternal death, low status of women, and socio-cultural barriers to seeking care, transport problem, and delay in receiving care supplies and personal things are not fulfilled, and poorly trained personnel with punitive attitude and finances. Antenatal care coverage. Antenatal care coverage is defined as the proportion of pregnant women attended at least once during the current pregnancy by a health professional such as extension practitioner for reason related to the pregnancy. Calculating the antenatal care first visit coverage provides information on the percentage of women who use antenatal care services. The antenatal care coverage rate is calculated as the total number of pregnant women attended at least once during their pregnancy by a health professional for reason relating to the pregnancy, divided by the total number of expected pregnancy during a given time period, usually 1 year, in the catchment area. The result is expressed as a percentage by multiplying 100. Antenatal coverage rate, number of first antenatal visit, and total number of expected pregnancy. For example, if the total number of first antenatal visit is 100 and the total number of pregnancy is 200, then the antenatal care coverage in your community will be 50%. In three delays model, there is also one model which is fourth delay, to take responsibility for maternal mortality. This is fourth delay. And now it's time for the recent updates. In recent updates, there are new strategies which is known as RMNCHA. R for reproductive, M for maternal, newborn, child, and adolescent health. Maternal and child health cannot be improved in isolation. Adolescent health and family planning have an important bearing on the outcomes, and the approach is comprehensive life cycle approach for improving maternal, neonatal, and child health outcome under neonatal, reproductive health, and maternal and newborn health, and concept of continuum of care. There are different life stages in which newborn period, and then comes the childhood, adolescent, and then the pregnancy. And the all aspects are covered in this new strategy RMNCH plus A. Reproduction, maternal, newborn, child health, and adolescent. Across levels of care, health facilities at various levels, outreach services, and family, home, and community care, and appropriate referral and follow-up. The White Ribbon Alliance. For Safe Motherhood, this is a grassroots movement that builds alliances, strength capacity, influence policies, and inspire action to save the life of women and newborn around the world. Goal number 3 in SDGs Sustainable Development Goal number 3 is related to the reproductive and child health, good health and well-being. And their goal 3.1 says reduce the global maternal mortality ratio to less than 70 per 10,000 live birth, and preventable death of newborn and child under 5 years of age, with all countries aiming to reduce neonatal mortality to at least 12 per 1,000 live birth, and under 5 mortality to at least 25 per 1,000 live birth, and ensure universal access to sexual and reproductive healthcare services, including information and education for family planning and the integration of reproductive health into national strategies and programs. Safe Motherhood in Pakistan, Past Failure and Future Challenges. The death of Pakistani women during pregnancy, delivery, or immediately after delivery of newborn is a calamity of incalculable dimension, not only for her family and community, but from perspective of health policy maker and planners of paramount significance to the health and well-being of the country. As we move into 21st century, the real challenge facing our nation in the context of safe motherhood is the implementing maternal health policy. The essential core of Pakistan's Safe Motherhood Initiative should be intersectoral, multi-level, pragmatic framework that links the common woman and man in the community, the ops, midwife, nurses, and educator, and is supported by a strong political commitment at the national, provincial, and district level. For the implementation of safe motherhood in countries, there is a launch of a mother baby package. And what is the mother baby package? The mother baby package describe each intervention needed to achieve safe motherhood in the short term. It represented the synthesis of activities at different level of the healthcare system and define a basic set of health system intervention and activities that cannot be further reduce. The package describes simply intervention needed before and during pregnancy, during delivery, and after delivery for mother and newborn. Some intervention can be delivered at community level by ensuring that women and their families have the information they need to care for themselves during pregnancy and deliver and seek assistance when appropriate. Much of this information can be channeled through community based facilities such as health posts, dispensaries, and trained traditional birth attendants. Implementation of mother baby package. The district health system is the basic unit for planning and implementing the intervention outline the mother baby package. The district provide a mechanism for linking families and communities with health center and hospitals in a functional, cost effective manner. Through district based implementation of intervention, it is possible to ensure that health services are available as close as possible to people's home. Now it's time for the MCQs. Ending preventable maternal death must remain at the top of the global agenda. Maternal health services that make pillar of safe motherhood, adequate medical care by skilled health professional, personnel before, during, and after childbirth, prevention of mental health issues, prevention of gastrointestinal infection, and provision of safe drinking water, provision of adequate nutrition. A. Yes, A is the right answer. According to WHO, 75% of nations in the world have a high maternal mortality rate. Which of the following has positive impact on health? Early marriage, female genital tract, inadequate nutrition, anemia, adequate health service coverage. E. E is the right answer, adequate health service coverage. The majority of maternal deaths are avoidable with prompt intervention by a qualified health practitioner working in a supportive atmosphere. Which of the following is indirect cause of maternal death? Hemorrhage, unsafe abortion, anemia, obstructed labor, heart disease in pregnancy. Indirect cause. Indirect cause. Yes, E is the right answer, heart disease in pregnancy. Of the 40 verbal autopsies, 35 women delay seeking medical attention in ABC hospital. Understanding the seriousness of complication, cultural beliefs and norms, experiences with the healthcare system are all blamed for the delay. Some people have mentioned a barrier to getting medical care as not having enough money. In this scenario, the critical level of delay is first level delay, second level delay, third level, fourth level delay, or fifth level delay. A. A is the right answer, first level delay. The proportion of pregnant women attended at least once during the pregnancy by a health professional such as healthcare practitioner for reason related to the pregnancy, attended birth, antenatal care coverage, maternal care, health service coverage, or birth spacing. B is the right answer, antenatal care coverage. The three delay models identify three critical phases that could directly affect the mother's and baby survival. The third level of delay is lack of transport, lack of money, lack of trained staff, traditional beliefs, transport cost.
A.
C. Lack of trained staff. Basic ops and newborn care is crucial to lowering mother and neonatal mortality. The following are not included in emergency ops care: manual removal of placenta, hysterectomy, blood transfusion, C section, administration antibiotic, and uterotonic drugs.
E.
Hysterectomy is not included in emergency ops care. In the ABC community, if the total number of first antenatal visit equals 100 and the total number of pregnancies equals 200, the community antenatal care coverage will be 30%, 40%, 50%, 60%, or 70%. 50%.
E.
This is the solving of this problem. Antenatal care coverage rate 100 is the visit in first trimester, and 200 is the total number of pregnancy in that community, and it is multiplied by 100, and the answer is 50%. The three delay model is being used in the ABC research project to examine its applicability and potential to assist a solution based strategy for gaining access to intrapartum care in the XYZ community. The study resulted in the conclusion that a shortage of equipment and supplies in the healthier facilities is to account for the delay. In this scenario, the critical level of delay is first level delay, second level delay, third level delay, fourth or fifth level delay.
B.
C is the right answer, third level delay. If properly developed, community-based safe motherhood intervention can effectively address all barriers at the family and community level. No safe motherhood program can successful until delays are addressed. Cultural factor, socio-economic factor, transport cost, poor attitude of staff. By providing adequate health education and awareness, well as skilled personnel and improved transportation services.
E.
E is the right answer. This is the key of MCQs YouTube link of this presentation where it is uploaded. And thank you very much.
Okay, thank you very much, Dr. Naila. This is a very nice presentation. However, there are a few points that must be highlighted. Number first, you have described about the antenatal coverage rate. That is a very important concept, and I must appreciate this that you have presented this concept very well. The second important thing is about the delays. We know there are two models. One is the 3Ds model, and other is the 4Ds model. You have presented about the 3Ds model. However, the most recent one is the 4 delays model, where the first delay is delay in decision making by the person and its family members or his or her family members. The second important delay is the delay in transportation due to the bad roads or due to the poor transport services. That is why the 1122 and the flying squad services that are playing the crucial role. The third is at the service delivery site or the facility site, there is failure to identify the life-threatening condition like antenatal or antepartum care or hemorrhages. Fourth important point is vulnerability, and there are many important things that have been done in recent past that must be included. There is no research paper that has been given here. Would you please go to the recent advances, please?
Yes, ma'am.
Okay, please stop recording.